So we're trying to double stream at the same time. Shounuck Patel and Rob Watkins. It's our first Facebook Live. We're new to this. We've set it up. We're ready to roll. We're podcasting at the same time. So look at us. We're hot and fresh. And so we appreciate you joining us on a Wednesday night, 7:30. What we're going to talk about is the stem cell madness that's taken over the world. You know, we've got a lot of patients, friends, and family, even ourselves, that are interested in stem cells and want to know, are they going to work? What's the utility? What are the risks? What's the safety? And if you go on the internet, even on TV, anywhere, there's marketing for stem cells all over the place. And where's the validity and where's the truth in it? And so I appreciate you coming today.
Absolutely.
You know, this is the first time we've actually met in person, and we're going to go at it tonight. We're going to get heated, and we both have the same goal. We just want to help people and find out where the truth is. And the story about us getting together is great. In fact, it was Bo Daniels, the chiropractor for the Rams. I take care of the Rams. We were talking on the sideline about stem cells, and he recommended you. He said you had a lot of experience. He had seen good results with patients that you had done, different injections on, procedures on. And so I invited you to our conference, which we're doing June 1st, for physical therapists, athletic trainers down in the marina in Playa del Rey. We have like 300 people show up, and it's a great conference. So I appreciate you, coming to speak.
Absolutely.
And then I put out a podcast last week on, hunting for stem cells and stem cell madness and where's the truth. And I love it. You actually listened to it, and you wrote me an email and told me where I was wrong, all these things, and what. And so I said, well, let's do a podcast together. And you said, sure. And then I called him yesterday, and I said, hey, let's Facebook Live it. You ever done that? He goes, no, but let's do it. So I love your enthusiasm,
Absolutely, absolutely.
There's all these cool mediums. I have an app and podcast channel, and it's just so cool that you can hit a play, create this content. We can share information. One of the things that I realize more and more is, we've got 10 years of training, 15 years in practice. The cumulative amount of knowledge we know about these subjects is so valuable to people, our friends and family and patients. They don't know anything about the whole basis for it and how are they making decisions on their life that affect them forever. And us being able to just hit play and talk and put some information out there is so cool.
Yeah.
It's so fascinating.
Now, what I love about this is that we can be real.
Yeah, right.
We can just talk,
right.
And we can talk about what we do and what works, what doesn't work, and now people can learn about it.
Yeah.
So that's fantastic.
And join the journey with us.
Yeah.
Sometimes we give lectures, write chapters, textbooks where you have to kind of have the definitive answer. And well, we don't have the answer yet. We're working it out. So
that's right.
Welcome to our brains and our worlds. And as we're sorting this out, and we'll see what makes the most sense, and we'll find out what we think is really safe to do. So why don't you go ahead and introduce yourself? Tell everybody who you are.
So my name is Shounuck Patel. I am an interventional physiatrist right here in Beverly Hills. My background is in what's called physical medicine rehabilitation, which is non-operative orthopedic medicine for all intents and purposes. I did a fellowship in sports medicine and interventional pain management, and I have been working in the regenerative medicine space for over 4 years now as a part of the RegenX network, which is really an international network that has been doing research and development in stem cells and other orthobiologics for over a decade at this juncture. RegenX has published nearly 50% of the world's data on bone marrow aspirated stem cells for orthopedic conditions. And we've basically been continuing to collect our data and base our procedures off of that because, as you know, data is king.
Yeah, and it's hard to come by. And it's hard, I hold new products to a high standard of where's the data, where's the randomized controlled studies, The reality is they're hard to get. It's hard to get 1,000 patients, treat 500, do a sham procedure on the other 500 to prove a difference, when placebo effect has a 30% success rate just from telling somebody you did something to them.
Absolutely.
So it's hard to get the data.
And that's the hard thing is, with randomized controlled trials, right? That data is hard to come by when it comes to anything musculoskeletal, right?
Yeah.
Anything surgical, anything physical therapy, anything, or definitely anything orthobiologic. It's just hard to come by. So, that's what it comes down to. What we're talking about is it's the practice of medicine, right?
Yeah.
We're constantly learning and moving forward.
Yeah. So an introduction for me, I'm Robert Watkins. I'm the fourth. I work with my dad. We've worked together for 16 years here in Marina Del Rey. We take care of a lot of athletes. We take care of most of the local teams, the Rams and Dodgers and Clippers and USC, the athletic department, and the Kings. And so we take care of a lot of athletes, but 95% of our patients are just normal people, age 18 to 90, who are in pain. So back and neck pain, we do spine surgery, but I also do injections. I actually trained in England for a year, where I had to do all the epidurals and facet injections at the end of the day. You know, as part of my job. And so when I came back to America, I kept doing the injections. So I still do epidurals, and lumbar and thoracic. I don't do the cervical ones, but. And I'll tell you my basic approach, especially taking care of the athletes, but everybody right now, I still inject cortisone or depomedrol, you know, prednisone. An anti-inflammatory steroid works. It's been around for 50 years. It's the best anti-inflammatory in the world. You know, anybody who's ever has pain and takes some prednisone knows it treats the pain better than anything. And the injections we know are reliable and they work. And so that's what I do on all the athletes I treat, because we got to get them back as fast as possible with the most proven track record, safest thing. So we're going to inject that. Plus, most of the athletes are men and women who are 18 to 25 years old, and their body can handle some steroid. And it's not that big of a deal to me. It's really low risk, but, you know, but there's always risk. But anyway, it has the most reliable chance of getting them back to be able to train, do their rehab, do their core stabilization exercises, and it's most reliable. So that's what I use. But at the same time, I've got a lot of athletes that are interested in stem cells. You know, they got people talking at them from every angle. Stem cells, PRP, Regenokine, Orthokine, you know, all these different products. And there's some real validity to if these natural biologic products that come from your own blood, for one thing, that's some of them, are safe and effective. Well, and if they come from you, well, they can be better for you than the steroids, because we know steroids have a bad effect on the body long term. If you inject them in joints, they can be bad. They can erode cartilage. I do epidurals mainly, which aren't in a joint. They're just in a space around the nerves, so they've never really been shown to be destructive.
Right.
You know, you can have 4 to 6 epidurals in a year for like 3 years, never really shown to have that real negative effect.
That's sad.
Go ahead.
That's sad. So I'm coming from the viewpoint that I've done epidural steroid injections. I treat more than just the spine. I treat peripheral joints as well. I used to do cortisone injections into joints. And I think that there's a time and place for it, right? With everything in medicine. I think there's a time and place for an epidural steroid injection. If someone has a young radiculopathy or sciatica type of symptoms because of a disc herniation or a disc bulge that's single level with no other things going on, yeah, you're right. You know, an epidural steroid injection might be enough in combination with the appropriate physical therapy, training, etc. But once you start getting older, the truth is the risk of cortisone is there. You know, a single cortisone injection can increase the risk of osteoporotic fractures in females, right? You know, when you talk about things like diabetes, I've personally witnessed patients that went into the 400s with their blood sugars after a single epidural injection.
Yep.
Right, so these are real things. We've seen postmenopausal females get their period back, and premenopausal females lose their periods, right?
Yeah.
So these cortisone, especially at the high doses that a lot of folks use these epidural steroid injections with, that there's risks associated with it. Now, what's interesting is there's some studies that show that lower doses of cortisone do the same thing as the higher doses for epidurals.
Right.
But for some reason, you know, everybody's using those high doses. So,
right.
But like you said, you know, if there is an opportunity to have something that is more natural, provide this, if it's the same exact benefit as the cortisone injection, but it is natural, then has less of the side effects, then that's kind of a win.
Yeah.
Now, what's interesting is looking at our data with Regenex, and this is at least, this is just data looking at patients retrospectively. So looking at patients that had previously had epidural steroid injections versus patients that had what we call epidural platelet lysate, which is growth factors from the blood, similar to PRP. Essentially, the patients that had the epidural platelet lysate had significant improvement in their symptoms for a longer period of time than those with epidural steroid injections. So we know that steroid injections only last for a few months, right?
Right.
So if we can have this last a little bit longer, then that's a win.
Yeah. So are there any patients that, like you mentioned, if somebody has an acute disc herniation, a fresh disc herniation hitting their nerve, causing sciatica, the pain's agonizing or going down their arm, and where you said prednisone is pretty effective, is there any of those hot, fresh cases that you would do the PRP type of injection?
Not necessarily.
Instead?
Not necessarily, and quite frankly, that's just not my patient population.
Yeah.
The couple times that I've seen patients that had hot radiculopathy, I've actually injected epidural steroids.
Yeah.
I have given oral prednisone, oral steroids. Because if it's hot, if it's something new, you know, that might not necessarily be a situation where an orthobiologic would be of benefit. But when things have been going on for a while, right, if you have a disc herniation or a disc bulge that's causing pressure on a nerve that's been going on for a long time, God knows you're going to have changes to your facet joints in the back. You're going to have changes to the ligaments. You're going to have, you know, your small little muscles, your multifidi are going to atrophy. So there's the whole system that gets involved as time progresses. And this kind of goes back to the surgical literature of Punjabi and White and treating the functional spinal unit, right?
Right.
We want to treat that whole picture rather than just treating that radiculopathy.
Right. So how do you decide between the PRP type of injection versus stem cell injection?
That's a great question, and that's a question that we get all the time because a lot of patients come to me looking for stem cells, right?
Yeah.
It really comes down to is what are we treating? So most of the time for spine conditions, I'm actually using PRP and platelet lysate. Mm-hmm. Why is that? Most of the time people are coming with, you know, sciatica, pain running down their leg, or pain coming from their disc, or pain coming from their facet joints. Although people argue what causes pain most frequently, right?
Yeah.
That could be another discussion entirely.
Right.
But ultimately, using your own PRP, your own platelet lysate, can be enough to improve pain, improve the strength of some of the soft tissue structures, and calm down the inflammation or irritation of the nerves.
Right.
What's interesting is, you know, there's a paper, 5 years ago, looking at epidural steroid injections for spinal stenosis or narrowing of where the nerves are traveling, right? They could be multifactorial. It could be caused by disc herniations, facet arthritis, kinking of the ligaments.
Yeah.
And the study showed that epidural steroids had the same effect essentially as epidural lidocaine, just numbing solution in the epidural space for people that have stenosis.
Right.
So what if we can have something that's injectable that can strengthen the ligament and take pressure off of the nerves? What if we can strengthen some of the muscles back there? What if we can put something into the epidural space that actually may reduce the disc herniation a little bit?
That's a stretch.
That's
a stretch.
No, I normally would agree with you. Now, again, this is on a case-by-case basis, but I've had patients that have had reductions of disc herniations.
Well, of course. Everybody has.
Of course.
The faith healer has.
Of course.
Your priest has. And the
course.
reason why is because 15% of disc herniations resorb completely on their own with no treatment whatsoever.
Absolutely.
And that's one of the downsides of any treatment out there.
But
any treatment can say they claim credit because and 50% of it, so 15% they resorb completely. Your body recognizes it's not being used, dissolves it with enzymes, gone. 50% of the time it gets a little bit smaller because the spinal fluid, every time your heart beats, it pulsates up against the disc herniation and backs it off kind of like water against a rock. So any treatment can say, oh yeah, look, we did it, we claimed it.
Correct. Yeah. And that's why I don't treat those acute cases as much, right? Because what happens if you have a 49-year-old female who is an athletic personal trainer and group fitness instructor who has been dealing with radicular pain and weakness going on because of a large disc herniation at L5-S1 for years, despite physical therapy, despite epidural steroid injections, despite doing appropriate core strengthening exercises, and on repeat MRI, that disc herniation is still there, right?
Yeah, right.
So
but then you do this PRP type of treatment. What's it called again?
PRP and platelet lysate.
And lysate?
Yeah.
So you do the lysate treatment, and a stable disc bulge for 4 to 5 years gets smaller?
Correct.
That's pretty, okay, that's impressive.
That's correct.
Let me see it. Let me see the picture.
On my Instagram at Stem Cell Dr. Patel.
Nice.
I have the before and after of the, and now it's not completely gone.
Right.
But
and I got to check the quality of the MRI. Sometimes the MRI is done a little different places, so it looks a little different.
Yep. And I'm a stickler on before and after imaging, and I think that's really important, right? Because oftentimes we see these publications of case reports that have an image that's completely different than from before and after, and I'm like, you know what? That's not showing anything, right?
Much less a different person.
Right, exactly. But no, we've had some cases like that. Now, this isn't a panacea, right? This isn't something that's going to heal everybody like, you know, the hand of God, right? But this is something that's an alternative for someone that doesn't want surgery.
Let me ask you another question. I don't want to get too technical, but I know I got some spine patients out there who kind of know what, you know, and doctors and everybody else. it mentioned, I looked at that site, about the PRP lysate, and it talked about strengthening the ligament, which, the interspinous ligament, strengthening that, or the ligamentum flavum, which is buckled in, strengthening that. I don't think that's going to change stenosis anyway. Stenosis develops because the disc degenerates, it loses height, it bulges out. Everything loses height, and the ligament buckles in. So it can be strong as a rock, but it's still in that position. So in order to really change the stenosis, you got to jack it open, which requires a fusion, or you have to do a microscopic laminotomy where we go in and just take out the ligament, which gets rid of it. But actually strengthening it, I don't believe that's going to increase height back in the disc and unbuckle the ligamentum flavum.
So you're right, with a little asterisk at the end of that statement.
Yeah.
It won't strengthen the disc. There's nothing that we know, and kind of go back to the stem cell talk from before. There's people that are injecting stem cells into discs, and I do that for specific situations.
Yeah.
But we're not regenerating the disc. We're not growing the height of the disc.
Yeah.
That just doesn't happen. So you're absolutely correct with that.
Right.
What else is causing that kinking of the ligamentum flavum, right? What's attached to that ligamentum flavum more superficially? You have your interspinous ligament, your supraspinous ligament, you have your thoracodorsal fascia that's all tying into that. What if we can strengthen those things? Now, I honestly, I was doing it because I was seeing the results, but I don't often do it before and after MRI for my stenotic patients because I just assumed that it wasn't getting better, right? Even though the patients were symptomatically improving, I wasn't getting those after MRIs. So I had this patient 3.5 years ago. This patient that came to me, he had previously had an orthobiologic treatment for stenosis and radicular symptoms. Those radicular symptoms improved, but when he came and saw me, he had back pain and he had weakness in his legs. Okay? And I identified that his weakness was because he had severe stenosis at the L4-5 area because of disc herniation, because of ligamentum flavum hypertrophy, because of arthritis and the joints getting larger, right? He was very, very obese. And he was like, you know what, I just want to start moving again. I said, okay, look, we can try this. So I treated the functional spinal unit, the epidural space, I treated the facet joints, I treated the ligamentum flavum, the interspinous ligament, the supraspinous ligaments, all the things that are coming and attaching to that ligamentum flavum. And he had
injected all of them.
I injected all of them.
All right.
So with PRP, with platelet lysate, a combination of those various things. He had improvement of his stenotic symptoms. His cramping in his legs improved, his weakness improved. He was able to get back to working out, he was exercising, he lost weight, he was happy. Okay. Then last year, I get a call from him saying, hey doc, my leg symptoms are still gone, but I'm having a lot more back pain. Oh, by the way, I stopped working out. Over the last few months, I've gained back 30, 40 pounds or whatever it is. I had this back pain. I said, all right, let's get a new MRI. So we got a new MRI. And at that L4-5 level, he had auto-fused. Right? His facet arthritis was rip-roaring.
The one you injected.
Yeah. So, no, I didn't inject the disc. No, I didn't inject the disc.
So was the purpose to auto-fuse
the
segment? Is this a new fusion technique?
No. The point is, his facet joints were gnarly and arthritic. Right? He had gained a significant amount of weight, put pressure into that area. His ligamentum flavum hypertrophy had actually reduced.
All right.
His stenosis was actually a little bit improved. Was it great? No, it was still an ugly picture. But he no longer had those symptoms.
Well, an interesting part about the auto-fusion is if you stop the motion, when you do a fusion, you put in screws and rods, you stop the motion across the disc and the joints. And that has been historically a classic way to treat the stenosis because you stop the motion, it stops the symptoms. Whether the ligamentum flavum that had hypertrophied and was buckled in, and some of the, because bone spurs can resorb. You know, you get a big bone spur in your knuckle, it gets big, and that's the bone spurs, how your knuckle gets bigger as you get older. If you stop the motion and fuse it, the bone spurs will resorb. So the bone spurs might have resorbed in the facet joints, which allowed the stenosis to resorb.
Well, I mean, the facet joints looked worse, to be fair.
Right.
They were more,
but they stiffened up, so the extra overgrowth resorbed. And I realize we may be getting a little detailed here. I hope that we're not losing everybody with these technical terms, but
all the people signing in have all dropped off.
Yeah, they're like, screw it. You know, tell us about how they work. Tell us how they're going to save our life. But these are interesting. You know, for us, these are the things that matter. When you talk about injecting a spine for back, you know, everybody has back pain. over 50% of Americans have back pain, even more than that, and at some point in their lives. It's the number one cause for loss of work, loss of productivity, pain and suffering, divorce, can't play with your kids, everything. Loss of your job as an athlete is back pain. And then neck pain. You know, those are the first two. So the important part is when we talk about back pain, you talk about doing an injection for back pain, well, what are you going to inject? Because you have a disc. In fact, let me grab this thing.
He got scared and left.
Yeah. Boom, look what we got laying around. So you have a disc, which is 80% of all the weight bearing. All the action occurs in the disc. When people hurt their back, it's usually the disc. That's where all the biomechanical activity is occurring. When they're young, but, you know.
Arguably, that's a part of the mechanics over time.
Yeah, all right. It can fade out. It can fade out. Number two is facet joints. That's where the motion occurs in the back. Well, for every disc in the front, you got two facet joints, and they move. They can be a source of pain, you know, but usually, in my experience, people with disabling facet joint pain is like 5% of my practice. I just don't see them that disabling. Yeah, it can be sore and hurt, but that's just my gestalt and test I've done. Then the other thing is you got nerves coming out. At every level, you got a nerve coming out. You get a pinched nerve. That can cause back pain and then go down the leg. So one of the most difficult things about treating the spine is, what are you going to treat? What are you fusing? What are you replacing? What are you injecting? What are you focused on? And so the injections, we'll review this for everybody. You can inject the disc. You can stick a needle in the disc, inject the disc, and hope the disc regenerates. And you mentioned, as of now, nobody's seen a disc height increase of any significance. And that's a stretch, to get it to come back to height. Once it's collapsed down, it's probably going to stay about like that.
Yep.
And the hard part about that is, once it's really mechanically collapsed, injecting is not going to do much. Well, that means you got to inject them when they're big and plump and more normal biomechanically. Well, that's very early in the degenerative process. So if you're going to stick a needle and inject a lot of discs that are big and plump, you're going to be sticking needles in a lot of relatively healthy discs, which may cause trauma to the disc by puncturing it. Whatever you inject in there better not cause an infection, and it better help. And then another component of that is, well, how long is it going to last? Because the disc is acidic, it has no blood supply, it has no oxygen supply. Most things you're going to inject in there are just going to die. And so that's part of the difficulties.
And that's an important thing about the disc, right? So we know through studies looking at what's called provocative discography, right? Putting X-ray dye into the disc and seeing what that disc tear looks like, seeing if that causes somebody's pain. We actually know that those kind of procedures cause disc to degenerate more.
Right, by traumatizing the disc, by injecting it.
That's right. Yeah. So the question is, should we be injecting discs as frequently as some folks are? And there are some people that are doing stem cell treatments across the country, across the world, that inject every single disc that walks through their door. Is that an appropriate thing to do? The question is what is the stem cells doing? What are the stem cells doing, right? Are they actually protecting the disc? And the answer is we don't know. So I've seen patients that personally have gone over to other docs and had multiple discs injected, and they developed worse pain.
Yeah.
Right. So we got to be careful with that. What would be an indication to inject a disc is if somebody has a young, healthy, plump disc that has a tear that's causing pain.
Yeah.
Okay. Now that might be an indication to actually inject the disc. Because ultimately, there are some studies that suggest that injecting PRP, there's a couple randomized controlled trials. There are several case reports, case series of injecting PRP into the discs, as well as injecting stem cells. There's at least one randomized controlled trial and several case report studies of injecting stem cells into the disc with benefit, even in comparison to placebo. So the truth is that for certain specific situations, injecting the disc with a biologic could be a good thing.
Right.
Now, should we be injecting everybody?
Yeah. And that's the hard part where I talk about the studies. To really get a study to prove it works, you got to have 500 patients. Everybody gets a needle injected into the disc. Half get injected the biologic or the stem cell, the product. The other half get nothing injected or maybe a little saline.
Right.
So that means 250 people are going to get a needle stuck in their disc and no treatment.
Right.
And you may be traumatizing the disc. That's why that study is never really going to be done. And as a scientist and a doctor, we want the data. Well, you're never going to really get that data. Plus, the cost of that study would be like $5 to $10 million. And who's going to pay for that?
Putting that aside,
Yeah.
is that, if you're just doing a study of injecting the disc, you're missing the rest of the functional spinal unit.
Right.
Right? If you're doing a study to just inject the facet joint, or there's a study looking at PRP injected into the multifidi, right? But you're avoiding everything else that's a part of the picture. And that's what's inherently difficult. We can do these studies, we can do these cases, and that's why I think cases, believe it or not, cases are the bottom of the totem pole when it comes to actually seeing some validity, seeing some scientific scrutiny, right? But the truth is, cases give us a lot of information, because we can see when an individual patient, and you apply information from other actual randomized control studies and apply that to an individual patient, how does that patient do? I think that's why case reports are actually really important.
Yeah, they are. And what's this say? Injections.
Oh yeah, we have comments.
Yeah, did ligament and flavum injections reduce infolding, physical reduction, or anti-inflammatory effects?
It's a great question. Well, the question is, what are the biologics doing, right?
Right.
When we talk about...
And let me ask you a question in terms of how I think about it. The injections that you're doing, are they an anti-inflammatory like a steroid, or are they regenerative, where they're actually getting discs to heal and to create something new? Fountain of youth type of...
The answer is yes.
Yeah. Both? Is that a yes to both?
It's actually yes and no, right?
Yeah, right.
Because, look, first of all, let's take a step back from even answering this question. I apologize. You're going to have to wait through this.
Yeah.
But what are the things that we are injecting?
Yeah.
Right? What are stem cells? What is PRP? What's platelet lysate? So just starting with PRP, and this is the way that I describe it to patients, right? So forgive me for all the docs in the audience that want some more higher level vocabulary here. PRP, when you cut yourself, platelets are the things that stop the bleeding.
Yeah.
Right? Those platelets contain growth factors in them.
Yeah.
And those growth factors are released over time, and those growth factors do different things. There are anti-inflammatory growth factors. There are pro-inflammatory growth factors.
Right.
There are growth factors that do chemotaxis, or bringing other cells to the area, including the local stem cells in the region.
Right.
Important.
Right.
So as PRP is a concentration of those blood platelets, and that concentration will then cause inflammation and then take inflammation away.
Right.
That's essentially how PRP works.
Right.
And part of that response is calling the local stem cells. So why does it work in some situations and not in others? So we have studies now comparing PRP to cortisone, as well as PRP to hyaluronic acid for things like knee osteoarthritis.
Right.
There's actually several studies now that show that PRP has better outcomes than hyaluronic acid. There's a couple that show that there's equal outcomes.
Right.
There's different types of PRP, and that's where the research gets all muddy, right?
Right. How many different types of PRP do you think there are on the market right now?
Well, so hypothetically, first of all, there's categories of PRP.
How many in LA are being offered? 30?
Maybe more.
Maybe 50. So when you say PRP and you go to your doctor and give me some PRP, there's 50 different types out there right now.
And there's different ways of administering the PRP, right? You can have blind injections of platelets into a knee joint where you need no image guidance, or you can have specific injections to specific parts of the knee joint, right? So there's all these different layers on that.
So back to the mechanism of the PRP. It induces this response of the host body, inflammatory and healing, and it heals tissue, it breaks down tissue, it starts the process.
Correct.
And we're basically assuming that because they're your own platelets, and these are a natural thing that occurs when you injure your body, that it's going to stimulate a positive reaction of what should happen to get it to heal, and it may just be amplified because you're injecting more of the cells there to get it to happen?
The idea is that it is causing a reaction.
Right.
Okay? So if it is a tissue that is injured, if it is a tissue that is stagnant and injured, right? We're not talking about acute injuries that suddenly happen. We're talking about something that's been sitting around for a long time and no longer in a healing response. It's going to be invoking a healing response that's taking place there. Now, if we just inject PRP into a knee joint, what's it going to do, right? I believe that we need to not only inject PRP into the joint, but also inject into various different structures that may be stretched, may be injured, may be pulled, right? If the ligament is being stretched because of their mechanics, you want to inject those ligaments, but you also want to work on the mechanics.
Right.
So strengthening the appropriate muscles, and when we talk about the spine, strengthening the core muscles, you know, some folks have wonderful ways of teaching patients how to. He's got a.
Yeah, you got our app, by the way.
Yeah.
The
Little plug.
The
Right?
Back Doctor app. That's our app, free in the App Store, Google Play Store. It's got the whole rehab program on it. Next.
But that is an important thing, right?
It's huge.
Because the thing is, you know, we can inject all these various things that develop a reaction to tell the body to heal. But if your body's not moving correctly, it's not going to heal the way that it should.
Now, let me ask you about this principle. I kind of try and strip things down. I don't take any supplements. I don't take vitamins. I just try and eat fruits and vegetables. And I think my body has everything it needs to heal. And even my wife is into meditation and energy healing. I've gone more down that path of, you know, yogis have lived till they're 150 years old with no stem cell injections, just by letting the body heal when it's injured by the natural process. So doing an injection of PRP, all these stuff like that, assumes the body doesn't have enough platelets and growth factors and stem cells there to heal itself. So how do we know it needs more to heal?
Great question. Question isn't, does the body have those things? Is, does the body have those things at those specific areas?
Yeah.
So a lot of times we're talking about areas that don't have appropriate blood flow, right? We're talking about areas that are deficient in their local stem cells. So, for example, there's studies that now show that a rotator cuff tear in the shoulder, the local stem cells in that area aren't working the way they should be. Right. So why is it the rotator cuff tear repair surgeries failed miserably a lot of times, right? Why is it that a study by Hernigou showed that putting stem cells in addition to a rotator cuff repair actually decreased the time frame for recovery and improved the healing rate, right? So, you know, it's that local area that does not have great blood flow. It's the local area that's not working the way that should be. That's where the biologics come into play.
So tell us a bit about the problem with case studies is you always have an example of how it works, and that's all we have to go by. Tell me an example of when it doesn't work.
Where it doesn't work is when there's mechanics that cannot be corrected. So, you know, for example, we're talking about knee arthritis, right? Yeah. If your knee joint normally works in this position,
right.
As we get older, the majority of patients, this is the right knee, starts to bow outwards a little bit, but you know, a certain proportion bow inwards. If that bowing has gone past a certain point, that no matter what muscle strength that we put into the rehab, no matter what we do biologic-wise to try to strengthen the ligaments, you're stuck in this position. It is what it is.
Gotcha. And so it's mechanically, which makes sense. Once you're past a certain point, it's not going to do that. What about...
That's where surgery comes into play.
Right. So for backs specifically, and then I'll try and branch out because I know I got people who are interested in their kids and parents and dementia and all these other conditions too. And
we got to talk about that.
Yeah. But for backs, because I'm a back fiend, and so for backs specifically, somebody has back pain for 3 years, done all the PT, done our app religiously. Believe it or not, they're still having some pain, and you know they've done everything, and but they're still having back pain for 3 years, chronic back pain. What injection would you do? Are you going to do a stem cell? Are you going to do the PRP? Does the cost matter? Is that a factor in the decision? And so therefore, you know, what would you do for a back pain? And you may explain it if the cost matters, and then what are the sources that matter, and how long do you think each one lasts?
So that's a loaded question.
Right. Right.
So somebody comes to me with 3 years of back pain or X amount of years of back pain. Question is, what's causing it?
Right.
Okay. What and
let's say they got 3 discs that are dark. They've got some disc desiccation, a little bit of degeneration on the humer, a little bit narrowed down, facet joints matching degeneration without much stenosis, really, kind of mild to moderate stenosis.
Sure. Yeah. In that type of situation, the imaging matters this much.
Right.
Right. Because as we get older, right, greater than the age of 30, greater than 30% of people have some sort of disc degeneration or disc bulge, even in the absence of pain.
Their physical exam, they wake up, they're stiff, it hurts, and then it loosens up after a hot shower after 30 minutes. They can get through their day, but then towards the end of the day, it starts to hurt some more. And that's 80% of my patients. Yeah.
So no, and that's a lot of my patients too.
Right.
We got to take that to the next level, right? Yeah. I go very in depth with their physical examination to see, are we dealing with any subtle weakness that's going on?
No.
Right. Yeah, it's easy to say no.
This is a hypothetical example.
It's easy to say no.
Right.
But the truth is that a lot of people will have toe weakness or dural
Right.
tension stretch, which
Right.
is a sign that there's some level of nerve irritation going on.
Right.
Or when we examine them, their muscles are more taut on one side than the other.
Yeah.
Right. So are we dealing with a facet issue, which
Right.
is your stiffness that gets better over time?
Right.
Are we dealing with the disc issue with pain is worse with bending forward or with coughing or sneezing?
Right.
Are we dealing with a subtle nerve irritation that might not be causing a rip-roaring pain down the leg?
Yeah.
But what exactly is going on? Or is it a combination of it all?
Combo.
And then in that combination,
Right.
based off of my physical examination and the imaging and the whole picture as a whole,
Yeah.
more often than not, I'm still using platelets as my first line.
Uh-huh.
When I would use the stem cells is if the arthritis in the facet joints is very, very bad.
Right.
If the disc has a specific tear in it.
Okay.
Okay.
You're going to inject the disc?
If it has a disc tear and if it is causing pain.
Okay.
Now,
All right.
but that is actually typically a younger population.
Right.
With the younger patient, CrossFit athlete, or any athlete, right? I've had back pain for the past, on and off for the past 5 years. I was squatting and then my back spasmed and it went out for 2 weeks.
Right.
Oh, but I've never had back pain before, right?
All right.
That's the type of that I would
I
inject
got you.
this.
That sounds pretty reasonable. And so, shifting from that, so you may try the PRP first and then try the stem cells.
Depends.
Yeah, depends if and you may, but you'll inject facet joints or disc with stem cells.
If needed, yeah.
What about ozone?
Great question. Ozone. So
Yeah.
for those of you that don't know about ozone, ozone is from our atmosphere, right?
Yeah.
And it's O3.
It's natural. What could be wrong with it?
There's free radicals and yada yada. The truth is we don't know how it works 100%. Now I am not, admittedly, I am not up to date with the research with ozone.
Yeah.
That being said, I did several years ago, publish a poster on the use of a case of ozone used in conjunction with botulinum toxin for somebody that had torticollis. It was an interesting case. But regardless, even then, and certainly now, I don't think we have the knowledge as to what ozone does.
Yeah.
I've seen patients that have had improvement with ozone. When I say improvement, let's backtrack a little bit. With all my PRP cases, stem cell cases, or whatnot, if somebody says they had improvement within the first week,
Yeah.
placebo until proven otherwise.
Right.
I don't judge anybody until after the 2-3 month mark or even further.
Yeah.
Okay? Placebo is a true effect, but typically that effect tapers off and dips down after the 2-3 month mark.
Yeah.
Right? Rarely it does stay longer.
Right.
So I've had ozone patients that had improvement that was long term.
Yeah.
I've also seen patients that were injected epidurally with ozone that developed rip-roaring radiculopathy. So the truth is I don't know if and how it works. I have seen patients that benefited. I've seen patients that did really, really poorly with it.
Is the PRP treatment that you do less expensive than the stem cell?
The PRP treatments that I do are less expensive.
Do they, if you thought somebody was a candidate for either one, and so you're going to inject the same type of biology, do you think that one lasts longer than the other?
Yes, potentially. Again, it's somewhat of a loaded question, right?
Yeah,
because if PRP is relying on the growth factors causing decreasing inflammation, relying somewhat on drawing the local stem cells to the area,
Yeah.
right? What does the stem cell treatment do that the PRP doesn't?
Right.
The reason that I would use a stem cell treatment is if the local stem cells aren't great, right? So if the arthritis in the region is very, very bad, right? We see things like modic changes in the spine that are suggestive of damage, so to speak, of the local area, the local milieu. Would that be a circumstance where stem cells are more appropriate? And I don't know.
So you're kind of looking for more degeneration, but
Correct.
not so much that mechanically
That's
you've
exactly
gone
right.
past someone. That's reasonable. The and the reason why I asked that is because part of my question originally was, everybody asked me about the injections. One of the big questions is, well, what's the cost? How long is it going to last?
Yeah.
And therefore, is it worth it? And that obviously depends on how much money you have and how much pain you're in and what's the effect. And, you know, and I know that's really hard to quantitate.
Yeah.
And so even though I'm trying to get you to answer it,
I'll give you an example. So I'll give you 2 examples.
Yeah.
Okay. Both spine. One example of a relatively young patient. When I first saw him, he was about 39 years old. This was 4 years ago.
Yeah.
He had 2 levels of disc herniations.
Yeah.
Of disc tears.
Yeah.
And he had axial low back pain and pain going down his leg. And I talked to him about both options of doing PRP and platelet lysate or doing stem cells. By the way, when I do stem cell treatments, I actually do a combination of PRP, platelet lysate, and stem cells. Right? So if I'm injecting the disc with stem cells, I'm still injecting the epidural space with platelet lysate to calm the inflammation of the nerves, etc.
Yeah.
Okay? But I presented both options, and he was like, look, I want to be conservative. I said, look, I'd do the same.
Yeah.
So we did PRP into the posterior elements, all the structures, to try to tighten things up and take pressure off of the disc.
Yeah.
I platelet lysate into the epidural space, and he had improvement of his symptoms.
Yeah.
Now this was a guy that had failed epidural steroid injections,
Right.
had done physical therapy, the whole 9.
Right.
He had improvement, up to 90% improvement of his symptoms, and he was diligent with his home exercises afterwards.
Yeah. Right.
This is a guy that I told, look, if we can't get rid of the disc tears, then we may need to go into the discs.
Right.
He had improvement.
Right.
Other end of the spectrum, I had a female, single mother, wonderful. And this is an interesting story. Same type of situation, disc tears, pain going down her legs.
Mm-hmm.
We did the conservative treatment first. She had resolution of the pain going down her legs.
Mm-hmm.
She still had the disc-related pain.
Yeah.
So then we decided to go into the discs and do stem cells.
Right.
She again had substantial improvement of her symptoms. This
Right.
was 3 years ago now.
Right.
I found out after the fact that she had actually done a GoFundMe account
Yeah.
for her treatment.
Yeah.
It actually tore me apart. I don't like
right.
that, you know.
Yeah, right.
And I, you know, my company gets mad at me a little bit because I give discounts when I need to, right?
Right.
Because when patients need these treatments
Right.
and they want to avoid surgery, then what other options are there, right?
True.
And I'd rather them.
She got the opportunity for other people to help her, so they can
Yeah,
spread the love.
Right. But the truth is, she had benefit.
Yeah. Right.
A year and a half later or something along those lines, she was pirouetting at a Christmas thing with her daughter, and she fell and she had increased back pain.
Yeah.
Did I do another treatment on her?
Yeah.
Not at first, actually.
Right.
She actually did physical therapy, and she did fantastic.
Yeah.
I ended up doing like trigger points on her, and she did great. You
Yeah.
know, it's one of those things that's really fulfilling, because her other option at that juncture was a 3-level fusion.
Yeah, no, there's no question about that. And one of the hardest patients I have are people who come to me who want surgery. They've been in back pain for 2 to 3 years. They're 28 years old. Their life sucks. They're in agony. They can't do anything. And they just say, look, do something. And if I tell them, I don't think you should have a fusion. Artificial disc replacements can work, but there are going to be problems within the lumbar spine because you're only replacing the disc, not the facet joints and the nerves. And
The functional spinal unit.
there you go. It comes back. All right, I'll give you that one. And so I'll say, look, don't have surgery. And those people are the hardest ones for me because I don't have anything to offer them. You know, and we do the app. We got to put them on the program. I got a podcast on everything I recommend to avoid pain: diet, meditation, massage, cardio, everything.
Which, by the way, I think is a huge part of it. And
It
that's
is.
something that I talk to all my patients about
Yeah.
is the mind
Yeah.
and the nutrition.
It's huge.
That's
At all places. But still, then people say to me, I've done all that, and I'm still in agony. And so this middle ground, and that's why I'm hunting for stem cells, is because I got a lot of people who fall into that middle ground, that I don't think they should have surgery, but you want to help them, and even help them some, to give them that jump start so that then they can do the rehab and do all the physical therapy. And so I really respect that window. So let's move on to 3 different types of stem cells. Bone marrow aspirate, which is any orthopedist does. We do that all the time. Stick a needle into the iliac crest, into your pelvis. That's where the body makes bone. You can suck out some stem cells from that, and that's pretty basic, accepted medical procedure. There's fat cells, which a lot of plastic surgeons and dermatologists use because they do that. They get the fat, and then they get the stem cells. They inject them back into people's faces and extremities of every kind. And then there's umbilical cord stem cells, which are kind of a hot topic. And I'll just say for me, the umbilical stem cells, people say they're young and fresh cells. Like, you don't want to take my cells. They're already 47 years old. They're already dying. You want some fresh, new cells. So you got to get the umbilical cells, which makes somewhat sense, but then it's from another person. So you've got to process it where you don't kill all the stem cells, but you also don't get an infection.
And therein lies the problem.
Yeah, all right. Yeah, is it? That's a fundamental problem?
So that's the fundamental. Yeah. So let's talk about those three,
yeah,
right? So bone marrow stem cells, when we talk about stem cells, first of all, what's allowed in the U.S.?
Yeah.
That's the first question, right?
Right.
What's legal?
What's legal, and what can you talk about, and much less what can you put in print?
Right. That's actually a great point, because what you can put in print is anything, right? You can say anything at this juncture. Whether that's true or not is a different story. The only stem cell treatment, the only true stem cell treatment that is allowed in the U.S. is from the bone marrow.
Yeah. Okay.
Period.
Yeah.
For at least for orthopedic conditions.
Right. Because it's established. It's been around a long time.
Yep. It's been around for a long time. It's been used in many different ways. The FDA, which is kind of this hierarchy that oversees this, says that it needs to be autologous use, meaning that it's coming from the same tissue back to the same tissue.
Yeah. Same person.
Yeah.
Right.
And it needs to be less than minimally manipulated. So that is a very strong statement.
Right.
And it has been open to interpretation quite a bit, as has the autologous use.
Right. What does manipulation mean? What's minimal versus moderate?
Correct. Right. But as far as the FDA is concerned, and this is as recently as last year and the year before, the FDA has said that getting stem cells from fat is actually illegal. Illegal.
Huh.
So the way to get stem cells from fat is you need to create this stuff called SVF, or stromal vascular fraction.
Yeah.
In order to create that, you need to digest the fat, with a chemical called collagenase.
Yeah.
Supposedly there's some systems that can mechanically, and therefore less than minimal manipulation, right?
Right.
But the only standardized way of making SVF is through digestion. And that chemical digestion, per the FDA, is considered illegal.
Yeah.
So that's that. Now, are there people doing it? Yes. There's actually been several clinics. There's actually clinics here in LA that have been in scrutiny under the FDA. FDA sent letters to them. The FDA has shut down a lot of clinics across the country. And it's doing that more not because this SVF is dangerous or doesn't work. The research in SVF is very, very low, but there is research internationally on it.
Right.
The problem is that there's a ton of clinics that take that SVF and they're saying, hey, we're going to inject your knee, but we're also going to inject it IV, and we'll treat your knee and your Alzheimer's all in one shot.
Right.
We're going to treat your diabetes.
Right.
We're going to treat your son's autism.
Right.
You're going to, all these crazy bogus claims that really are based on little to no research whatsoever.
Right.
So that's where SVF gets dangerous, and there's not the long-term study of outcomes.
Right. Although, in its defense, it's probably safe, because you're just taking your fat, putting it in, and injecting it back in. So you inject your fat into your IV, into your bloodstream, your body just goes, whatever, and pees it out,
Potentially.
Right.
But we don't know what the chemical digestion is actually changing it.
Yeah, right. True.
So we don't know what's going on there.
And part of the principle is anything that's powerful enough to treat Alzheimer's, autism, back pain, spinal cord injuries, anything that's powerful enough to do all that is probably going to cause cancers. Because it's so powerful, it's going to make cells. And when's it going to stop? How's it going to know, okay, you've done your job, now shut off and go home? No, it's going to keep working and create all sorts of crazy things.
And whether or not that's true, we just don't know.
Yeah.
Right? And so, as much as a lot of people in the regenerative medicine space are like, oh, FDA, we don't like you. Truth is, they're looking out for our safety to a certain extent, right?
Right.
So that's a big thing with the SVF type of thing. So that's not legal in the U.S. and
that's fascinating.
It's interesting
because it's done a lot.
There's tons of folks that are
going
still doing
all
it
over the place. Well, I was going to go up the street get an injection tonight.
Truth is, FDA doesn't have enough funds to shut everybody down.
Very true.
But there is a type of fat procedure that is legal. And that's micronized fat. And that's taking fat and just mechanically emulsifying it, making it very, very small, not liberating the stem cells from it, but just having the fat graft. And there is actually some interesting research that is starting. It's still fresh, but there's some interesting research for things like knee osteoarthritis, rotator cuff, areas where you might need to fill a gap, so to speak, right? If you have a rotator cuff tear, something like that might be of benefit.
So tell me about the umbilical cord while we're still on that.
Yeah.
I mean, this sounds pretty legit, right? These
Absolutely.
young little
I mean, who
fertile
wouldn't,
thing.
who wouldn't want, you know,
Right.
a baby embryo, right?
Yeah.
BS. So it's
Yeah? Really? Straight out?
So here's the thing,
Yeah.
right? There has been now 3 independent groups that have
Yeah.
looked at umbilical, amniotic cord blood tissues.
Right.
One of which including Cornell, a lab out of Cornell.
Right.
One publication that was just recently done in a national publication.
Yeah.
That shows that these umbilical, embryonic, placental products
Yeah.
don't contain any living stem cells.
You're right. Or minimal.
Or minimal. Or minimal.
Because not zero.
Potentially zero.
But
some of these
but
products,
much less than you think, or what they propose they do.
and the issue is, right, the process in which
Yeah.
you're, you know, some of these are gamma radiated to make them safe. Some of them are shock thawed and frozen, right? All of this process is going to kill the stem cells.
Let me tell you a quick story. I had this older gentleman who lives in LA who came in, and this guy's like 80, comes in, he's having neck pain. He goes, I couldn't get in touch, I couldn't get an appointment with you fast enough, you know, and I was having pain, so I went to my local guy, and he injected some stem cells in me. And, you know, I thought, I just went to bed. My wife, in the middle of the night, thought something didn't seem right, calls 911. They take him to the hospital. He gets diagnosed with sepsis. He had an infection in his whole bloodstream, could have died in his bed that night. And his wife just thought something didn't seem right. And the thing I've learned as a doctor is if the wife or husband, usually wives though, they're more
Yes,
perceptive.
yeah, to be
If
fair.
the wife ever goes, he doesn't seem right, something doesn't seem right, something's wrong, you better drag that man to the hospital and do some tests on him. And that's exactly what happened. And that company was Livion. I don't think I'm bad-mouthing anybody. It's just a factual story.
Yeah.
Got shut down by the FDA. It was in the LA Times. Oh, I had read about it in the LA
No,
Times
actually-
literally 3 days before. And this guy walks in. I said, what was the company? He goes, I think it was this Livion thing. I go, you're one of the cases. So
Yeah,
it happens.
And you know what's crazy? Livion did not get shut down.
Oh, I thought they did.
No, I think they made a week later, they miraculously made another product.
Yeah.
So, you know,
right.
I don't know the situation. Look,
We are not blaspheming Livion. We don't know anything about him. It's just a story.
and this is, you know, this is stuff that's on the news.
Yeah,
and
right.
and it's well known. You know, the New York Times, everybody's picked up the story about these like. You know, at the time it was 12, but now I think it's like 16 or 17 patients that
Right.
were hospitalized with this scrupulous stem cell treatment.
Right.
And I'm like, you know, I want to write this letter to the editor here saying, can you just put a little, you know, carrot and say fake stem cell treatment?
Yeah,
because
all right.
it's not living stem
So you're
cells.
not the umbilical one. All right,
No.
that'll be my next guest, is the guy doing the umbilical. And then,
But here's-
then he'll come out and say, oh, they're amazing, you know, all this kind of stuff.
But the truth is, what's in them and why do
Yeah,
they work, right?
right.
There are growth factors that are in them.
Yeah.
And there is something. There's a milieu. There's a
Right, they say this is the juice. It's all those growth factors, everything goes with it that stimulates the body to come and heal the cells.
And so what research is on there?
Let me ask you one other question about that is, what about people who have saved their child's or their umbilical cord, their child's umbilical cord, the combo, I don't even know, who does it belong to, the
Yeah.
mom or the child?
Yeah.
But they saved it, and they got it frozen away. What do you think of that? Do you think it's worth saving? Is it worth paying the $100 a month to keep
You know
it
what?
frozen?
That's a great question, and this is a very very topical question for me because I just had a baby girl.
Yeah,
a month
congratulations.
ago.
That's
Thank
right,
you.
I know, taking the
Thank
night
you.
off.
Yeah, I'm gonna get in trouble, but
Yeah,
hey.
right.
So no, I had a baby girl a month ago, and I have a 2-year-old,
Yeah.
less than 2-year-old boy.
Yeah.
So for my son, we saved his cord blood and
Yeah.
cord tissue.
Yeah.
Currently, the only use for that is if he develops a cancer, and particularly a cancer that needs to have his bone marrow irradiated or taken away. Instead of having to find a bone marrow donor that matches him,
Yeah.
he'll have his own banked.
Really?
That's
pretty useful. I mean, what are the odds?
I mean, the odds are low.
Do you know? Have you an idea what the
actually
actual
don't
number is? I
know.
wonder what it's. It's probably 1 in a million.
Yeah, I have no.
I don't know. I don't know either. But that's at least there's something. We know there's something, and that's today. 30, 40 years.
Yep.
So did you do it for both or
Nope.
just your son?
So I just and here's the thing, you know, I didn't do it for my daughter.
The girl looked tougher.
She takes after her mom, so she
Yeah,
is.
right.
No, but the truth is, I don't know what these companies are doing with
Yeah.
with the product, with the product, right, with these cells.
Yeah.
Because ultimately, all these companies that are out there that are making all these, you know, cord and amniotic and all these tissues, they're
Yeah.
getting these products from somewhere.
Yeah.
And a lot of them are public banks. You know, if you check off that bank's off that slip saying that you know what you're willing to sell it to or send it to research or whatnot, and that's might be where it's going.
Right.
Which is interesting. And the truth is, we don't know where our technology using our own biologics is going to go 10 years from now.
Right. But why didn't you do it for your daughter?
Just for that reason. You know, with the way things are going right now.
You don't think you'll need it?
I don't know if I'm going to need it.
Yeah, I got you.
Now, I'm still paying yearly for my son just because I've already spent money. Now I'm like, shoot, you know.
Right. Yeah, it's an interesting call. For me, I just said forget it. My kids are 11 and 13, and so it was but they asked. And I just thought I thought it was like somebody trying to sell me some insurance on my rental car. I was like, nah, forget it. I'm not paying anything. And kicked them out. My wife was like, who was that? I'm like, nothing. Don't worry about it.
Yeah, no, it's interesting. But that world, when you talk about the Wild West of stem cells, that's the world.
Oh, it's huge.
It's, you
know,
know,
a big market.
The hard thing is, with these stem cell treatments, really, if you're going to somebody, that you should be going to somebody that's a specialist in it.
Yeah.
Unfortunately, a lot of the amniotic, umbilical, etc., a lot of these are clinics, whether they're run by physicians or chiropractors or whatnot, they might have a nurse practitioner that's doing an injection that is not properly trained.
Right.
So I think it was just last week, Dean Cain, Superman, had a video that was just put online last week in an article associated with it saying that he got this stem cell treatment for his knee.
Yeah.
And the video shows a nurse practitioner doing an injection without any image guidance up here for his knee joint when his knee's back. And I'm like, first of all, where's she
I watched
injecting?
a couple of videos on YouTube where there's a doctor doing some procedure and you're like, whoa.
Yeah.
And and they're like, oh, I'm injecting the inner the spinous and you're like, that's not even a real structure.
Right. And the poor guy, like in the video, he starts doubling over because it's painful. I'm like, I don't know what's going on, but this wasn't right, you know?
Right. So, and then the last group is the bone marrow stem cells, and that's what you do. And so, why do those work?
So, bone marrow stem cells have the most research overall for orthopedic conditions.
Yeah.
And when we talk about bone marrow stem cells, there's stuff even in the bone marrow stem cell world that we can and cannot do in the U.S.
Yeah.
So we can't grow the stem cells out in culture in the U.S. We have to have a same day, same procedure type of situation.
Now you can send them off and they can store them for the person potentially for later. You can freeze them and store them.
There's a gray zone there.
Cut the mic.
There's a gray zone there, and I think that's by state regulation.
Oh, is it? Okay.
I think.
All right.
I think.
All right, but regardless, you can take them out, minimally manipulate them, and inject them back in.
Correct.
Yeah.
So as long as you're manually pipetting, manually centrifuging, there's a lot of kits that are available that could do this kind of stuff. We use our own lab setup where we manually do things ourselves.
Yeah.
That is perfectly legit.
Yeah.
And that's where all the research is. Not all, but that's where a majority of the research is for orthopedic conditions.
Right. And what's the downside? Do you believe these cells will be old? You're taking them out of some old person, injecting them back into the same old person?
The downside is pain. Because the stem cells cause a significant inflammation first before taking the inflammation away. Beyond that, there's actually some published research that shows, or published data that shows that the stem cell treatments are fairly safe.
Yeah.
There was a study a couple of years ago, 2016, by the founder of Regenex, as well as folks from Mayo Clinic and others that came together, pooled data, and said that the bone marrow stem cell procedures, and I believe some fat was included in that study too, has no significant adverse effects. Now, the data was only carried out for just over 2 years on average.
Right.
So it's still fairly young, fairly fresh. Looking at our Regenex data over years, we don't have any major adverse effects that are associated with it.
What about, so one of the things about stem cells is they're very early cells that are pluripotent, multipotent. They can become other types of cells. So you're taking the cells out of the bone marrow, which you would think are more predisposed to become bone, and you're injecting them, hoping they become disc or cartilage. I've heard of a case where it was injected into a knee and muscle formed in the knee joint because the cell doesn't necessarily know what it's supposed to become, and it became a muscle cell. You heard any cases like that?
Kind of.
Yeah.
In the cultured stem cell world.
Yeah.
that there's some case reports on that front, and that's why perhaps why it's not as...
When you say cultured stem cell, you mean the umbilical?
No, cultured bone marrow stem cells. So when you take the bone marrow out,
process
grow it out over time.
Gotcha, then put it back in.
Correct.
Okay.
Now with Regenx, we actually have a facility in the Cayman Islands. I haven't gone to because, Caymans is too far away from us.
Yeah,
sounds
nice.
I know. But they do cultured stem cell procedures there, and looking at their outcome data over time, there's no adverse events in terms of tumor growth. And why is that? So, first of all, the same-day stem cell treatments. Now, this is going to get deep. What are the stem cells actually doing?
Yeah.
Right? We used to think we take the stem cells from the bone marrow, we inject it into the disc, the joint, etc., and it's going to change into disc cells, or it's going to change into the cartilage in the knee joint, or it's going to change into this. It's going to change. That's not how it works.
Yeah.
We realized that stem cells in the lab setting can change down these different lines,
right?
But not actually in humans.
Yeah.
So the founder of what's called the mesenchymal stem cell, or MSC, Arnie Kaplan, 1991 named that the MSC.
Yeah.
Actually, over the course of the last few years, has said, you know what? That MSC, I want to call it a medicinal signaling cell.
Right.
It's no longer a mesenchymal stem cell.
Yeah.
Oh, I don't know what's going on over there. We're having some technical difficulties. Just give us 1 minute.
It's it's looping. iPhone, Facebook gone crazy. I think I'm just gonna. I guess I'm just gonna cut it. Whoops. It says save, upload. I think maybe we've maxed out the time. Share it. Post video to your timeline. That sounds pretty good.
Yeah, sure.
Any millennials watching? Help us out. Tell us what to do. It just stopped. Hit stop. We're going with both. We got big audiences out here. We're gonna go at it. Turn the sound off.
Yeah. Well.
So yeah.
So what I was saying.
Yeah, I'll send you the link.
All right, sounds good. So
instead of calling them stem cells, call them medicinal marking cells or
medicinal signaling cells. So it still
Bring
is
in
the
other
MSC,
stuff.
right?
All right. That's good. All right. Really confusing.
So what happens is, when we talk about stem cells, people think about pluripotent stem cells, and that's where people get worried about cancer growth.
Right.
Pluripotent are the embryonic stem cells that could change literally into anything.
Right.
Okay. They can change into all these different lines, including bone stem cells or mesenchymal stem cells. Nerve cells, hematopoietic cells going into blood cells.
Yeah.
So that's the pluripotent embryonic stem cell that is technically not legal in the U.S. and that is not in these umbilical products that are available on market.
Right.
Okay. The stem cells from the bone marrow, the primary stem cells in the bone marrow that we're interested in are the mesenchymal stem cells, or now what we call the medicinal signaling cells.
Yeah.
There's other stem cells in the bone marrow, hematopoietic stem cells that turn into blood, etc.
Right.
There's other stuff in the bone marrow.
Yeah.
There's growth factors, there's blood, there's platelets.
Right.
There's these things called exosomes, packets of information,
And
all
so
this stuff.
the point is those stem cells are not becoming necessarily disc cells. They're triggering the body to come and heal.
That's right.
Wake up the stem cells that are already there potentially.
Boom.
Get them going.
That's the thought process behind it. and that's how it works. And we don't even know if it's just the MSCs or if it's the MSCs in combination with all the other stuff that's in there.
All the other juice.
That's changing that environment.
Right. All right.
So,
all right. It's interesting. I think one of the things about doing bone marrow is you kind of got to know how to do it, and you got to have the setup and, not cause too much pain doing it. One of the things about the umbilical stem cells, why they are popular in certain clinical settings and offices, is because they come in a packet and they're frozen. And you can have a freezer and they're in a packet, you can take them out and inject them, which is a lot, it doesn't cause pain of harvesting the cells out of the person's hip, and it's a lot easier and faster. And so, and I think about stuff like that because I know in my world, what treatments do I do? Well, they got to make sense. I'm not going to go down to, I'm not going over the state lines to get the product or to do it. It's got to be here. It's got to be controlled. At the hospital, I can do a bone marrow aspirate because it's an orthopedic procedure I have privileges for. So I'm more likely to do that. Although, do the umbilical ones, we use fresh frozen allograft. We use allograft type products from cadavers that are over in the hospital in the freezer right now. So we do that too.
But I use allograft for specific situations too.
Yeah, do you? And that's part of it is, you know, when you're going to somebody who's going to do a certain type of procedure, you kind of want to know, are you doing this procedure because this is all you can do or do, or is it because you really think it's the best? And what's your rationale behind it? And so all those work. Again, it's like the plastic surgeons are going to do fat cells because they're sucking them out all the time. They got them. They got them laying around all over the office. They can inject them in anybody. But mild divergence.
Yeah.
Anything else you want to say about that?
No, I think we kind of covered the bit. Oh, the one thing that I was trying to say was that if somebody is doing an injection and on their website is saying that they treat the knee arthritis and the back pain and the Alzheimer's and your baldness and all this stuff.
If it treats everything, it's a little. I'm weary too.
It's suspect.
It is suspect. That being said, because stem cells are a primordial, basic cell that exists in all humans, it can become everything. They may be the cell that can cure everything. That is the theory. That is the potential. I mean, if of any cell that could do it, it would be it.
But that cell is not allowed in the U.S., so you'd have to go outside of the country where there are risks of other things happening.
I actually read Riordan's book, who's in Panama, has a whole clinic in Panama. Interesting book, but he had every condition you could think of and 3 examples of every condition and how it had saved people. Spinal cord injuries, injecting them into the spinal cord, getting the spinal cord to regenerate, which happens naturally. Most people have a spinal cord injury, regain 1 or 2 levels of motor function, which can be really vital. That happens. We know that happens already. So did it happen because of the stem cells? We don't know. But my point about just what you said, it was an interesting book. I mean, smart man, a lot of data, a lot of research. And I respect people who are on the cutting edge doing these things. At the same time, well, just what you said, it treats every condition. And all the examples, 3 examples of every condition and how it cured all 3 of them. And that's kind of my point. And what I asked you as a doctor is kind of like, okay, so I know you don't have the randomized controlled data to show this or that. You have some examples of how it works. Well, tell me some examples of when it doesn't work. Yeah. Because we know that they got to exist. Yeah. And so it's kind of like, just don't tell me the good.
Absolutely.
Especially as a surgeon, I've been in practice 16 years. When I go to conferences with other surgeons, I don't want to hear about how great this product is. I want to hear the complications and when it doesn't work. Tell me the bad stuff, because then, for one, then I'll believe you, and number 2, I'll know how to avoid that, and that's what really matters.
And that's where the data counts, right?
Yeah.
And not only the data that's published, but your own personal data. And this is to all you docs that are doing Regen Med or really anything out there. Collect your own data to see what's working and what's not. The truth is, it doesn't work for everybody. And there's a lot of docs out there that say, oh, this treatment will work for 90% of patients. I've seen this advertised on websites. Stem cell treatment, 90% better in all patients. I'm like, that's bogus.
Yeah.
We have our data published that's on our website, on the Regenix website. You can see what nationally all the data that's accumulated. And you can see that our numbers are greater than 50%.
Yeah.
But that's nowhere close to 90%, right?
Yeah.
So we need to know what works, but we also need to know what doesn't work.
Yeah, totally. Well, it's been great, and I've really enjoyed it. And it was a lot of fun. We'll do this every Wednesday. What do you think? We'll have some pizza. I promise you margaritas originally.
Oh, yeah, that's right.
Then I realized I got to operate tomorrow, so we'll have to hold off on those. But I hope this has been helpful to everybody. And basically what we can do is Facebook either one of us, questions, and we can answer them that way. We can do a follow-up. I might Facebook Live your lecture on June 1st.
Yeah, sure.
And we can do that, and you guys can watch more. And I'll come up with some more. I'll read some data and really grill them on the post thing there in front.
Yeah.
You can contact me at watkinsspine.com is our webpage. My email is robertwatkinsmd@yahoo. You can email me. You want to tell them your info?
Yeah, so my info, our website is www.healthlinkcenter.com. My Instagram is @StemCellDrPatel. My email address is drpatel@healthlinkcenter.com. So you can reach us at any of those. We have an education center that helps patients navigate this whole world of stem cells.
Yeah.
So that you can email them at info@healthlinkcenter.com.
Cool.
And they'd be more than happy to give you information about our outcomes, our data, and really clearing up some of the stuff that's really a myth out there.
Cool. All right, guys, thanks a lot. Thanks for joining us.
Thanks so much.
Have a good night.
And thanks for having me.
Yeah, man, that was fun.
Appreciate it.
All right, I got to turn this off so I don't walk home with it still on.
Yeah.